Hi, Dr. Brian Koffman, a retired family doc and the co-founder, executive vice president, chief medical officer of the CLL Society here at ASH 2023.
And I'm Dr. Adam Kittai. I'm an assistant professor at The Ohio State University, where I specialize in the treatment of patients with CLL and Richter's transformation.
Richter's transformation, fortunately, is a rare but very aggressive complication of CLL, and one of the only successful therapies is a transplant, but it's not done that often, it seems. Tell us what the role is for transplant, how that fits in. Why don't we see more on transplants in CAR-T? Yeah. I mean in Richter's, I'm sorry.
That's fine. No, so one thing to first delineate is what kind of transplant you're alluding to. So in this case, it's an allogeneic stem cell transplant.
Good point, yeah.
And so there's two types of transplant. There's an autologous stem cell transplant, which is basically you get really high doses of chemoimmunotherapy, and then you rescue yourself with your own stem cells. And then there's an allogeneic stem cell transplant where you're getting an entirely new immune system from somebody else. And so the reason why I just want to make this designation here is that we still do use autologous stem cell transplantation for diffuse large B-cell lymphoma and other aggressive lymphomas. But in this case, patients with Richter's transformation are classically don't respond to chemoimmunotherapy. And in order to get an autologous stem cell transplant, you have to respond to chemoimmunotherapy because that's the whole point. So similarly,
I'd also add that we don't do autologous transplants in CLL.
Yeah, exactly.
We use donor or family related, someone else as we import a new immune system.
Yeah, and that's partly because once again, our patients who have CLL typically are refractory to chemoimmunotherapy by the time that they get up to that point, if they've ever received chemoimmunotherapy. And also patients with CLL typically have a lot of CLL in their bone marrow. So it's hard to rescue someone with a high dose chemotherapy when their bone marrow is already sick with the cancer, right? And so in terms of allogeneic stem cell transplant with Richter's transformation, one of the main things that needs to happen in order to get an allogeneic stem cell transplant is you need to have good disease control prior to going into transplant. And so that's the main barrier to getting patients with Richter's to a allogeneic stem cell transplant. It's because we don't have good enough therapies that get our patients in good disease control. And so anecdotally, and I was just talking to a colleague about this, I finally had my first patient who has gotten into a CR with
complete remission
with venetoclax plus R-CHOP on our clinical trial that's being run by Matt Davids out of Dana-Farber and Dr. Rogers at OSU with me. And I referred her to transplant. So she's now going to go talk to our transplant colleagues.
And that's because you know that as good as this is, it probably won't last based on the historical data.
Exactly. And so because it won't last based off historical data, she should really think about getting an allogeneic stem cell transplant. Now, I'm keeping my fingers crossed for her that she doesn't need it, but we really have no way of predicting that before we go on to get a transplant. So that's something that I have ongoing discussions with this particular patient.
What a difficult situation for the patient because they're doing well, they're in a complete remission, and you're saying but,
yeah.
And the patient wants to ride it, but they know that they may not be able to ride it for too long.
Yeah, and getting an allogeneic stem cell transplant is a huge decision, right? So it comes with significant toxicity, lifelong toxicity that patients really need to weigh before making that really tough choice.
And it comes with a risk of mortality related to the transplant itself from infections and complications. Yeah.
Exactly. And so in the end, I think that for patients who are able to get really good disease control, I do consider an allogeneic stem cell transplant. It's tough to get them into good disease control. And one more point to mention too is that an allogeneic stem cell transplant is really tough on older patients. And so because our patients with CLL typically tend to be older, sometimes their age prohibits them from getting that transplant as well. So it's not only the fact that it's tough to get good disease control of their Richter's transformation prior to the transplant, but sometimes their comorbidities, including their age, makes it difficult for them to get transplant as well.
Any final thoughts on transplant in Richter's?
Yeah, so I think even with some of our new therapies are coming out, I think that transplant should definitely be a consideration. And I think that if you have Richter's transformation, getting that second opinion from somebody who sees a lot of Richter's transformation and from a site that's able to do transplant or CAR T is really something that our patients should be informed to do.
Yeah, and the only curative therapies are these cellular therapies, and that's why I'm excited about the potential role of that. And I would push a little bit that we are doing older and older patients for transplants. So a friend of mine at 70 just had a successful transplant for Richter's and is doing great. So it does happen.
Yeah, and at OSU we have a specific doc who sees those patients who are older who are interested in transplant. And she always talks about how age is just a number and that if you have a fit patient, there's no age cutoff at OSU.
Dr. Kittai, thanks so much for what you're doing. This is such an important area and such a hard area of research. Thank you.
Thanks for having me.